Hello, good evening, everyone. So welcome to the third session of our National Virtual Graduate Medical CME, that is Navigate Medico CME. So welcome to the third session. So now, first of all, I would like to invite Professor Umesh Kapil, the Secretary of NAMS, to give the welcome address to the audience.
Good evening to all of you. It's a great privilege to have all of you again with our CME program. I would like to express my most sincere thanks and welcome to Dr. Kameshwar Prasad, who is the Director, RIMS Ranchi, who has been earlier head of the Department of Neurology and CN Center at AIIMS. My special welcome to Dr. Padma Srivastava, who is presently the head of the Neurology and CN Center at AIIMS. My special welcome to Dr. Praveen Agarwal, who would be joining us and delivering a lecture on poisoning, how to undertake it. This is a very important area which has been there. And over to you, Dr. Kameshwar Prasad, sir. Namaskar.
So thank you, Professor Umesh, sir. So now I would like to invite Professor Sareen. Professor S.K. Sareen is the president of National Academy of Medical Sciences. So I invite sir to kindly introduce about Navigate Medico CME program, please.
Thank you, Jaswant and Preeti, who are helping us through this CME Navigate program. The NAMS, which is a body of experts, fellows, members, associate fellows, we want to reach out to all those who are either preparing for exams, for postgraduate, or who have tried and have not been able to reach to the postgraduate or super specialty level, or they want to increase their knowledge in their clinical and increase their clinical acumen in their day-to-day practice. So this is an overarching program, and we have modules every 2 weeks. We would like you to join it. We would like you to tell your other colleagues to join. And also, we would like to give your feedback how to improve. I put every time myself into the shoes of the student. I don't know this, I don't know this, and how rapidly, how clearly I can learn. So we get the best of the experts in the country to teach you in a very short time, giving you like a capsule and giving you the pearls of experience and their wisdom. So please popularize, please tell everybody. And I also want to make a request to all the residents and fellows who are listening. We want to have a competition for the best logo for Navigate CME program. I would like to humbly put it an award of rupees 10,000 for the best logo design for Navigate Medico CME program. It will be your program. It will be a program with your logo. So I would like in next 2 weeks time to send your design to the program, and I'm sure when you see your own selection, you will be very happy. With this, we have 2 outstanding speakers today and an outstanding and senior chairperson. I'll hand over to Jaswant to continue this. And thank you for joining, and make sure that you learn and give a feedback.
Thank you very much, sir. So continuing the CME, Now I would like to welcome our chairperson for the first session, that is approach to an unconscious patient. Our chairperson for this session is Professor Kameshwar Prasad. He is current director and CEO of Rajendra Institute of Medical Sciences, Ranchi. He has been a former professor and HOD Department of Neurology and Chief Neurosciences Center at AIIMS, New Delhi. He has been former chairman stroke subsection in Indian Academy of Neurology. He is member of WHO Strategic and Technical Advisory Group, reporting directly to the DG WHO. He is nominated editorial board member of British Medical Journal and Practical Neurology. He is nominated editor of Cochrane Stroke Review Group. He is chairperson Stroke Guideline Subcommittee, DGHS, Government of India. He has multiple publications and multiple awards to his credit. So now I would like to invite sir to chair the session and kindly introduce the speaker for the first session, Professor Padma. Yeah, so over to you, sir. Thank you, sir.
Thank you very much. I must first acknowledge Dr. Shiv Sarin's vision, who has really started this new activity, which is being, I think, steered by Dr. Umesh Kapil, who puts in so much effort to organize this and gets the best speaker. So for today's speaker, Dr. Padma Srivastav, needless to say that she is best placed to talk on the topic of how to approach unconscious patient. I'm proud to say that she has been my student, and now, of course, professor and head of Department of Neurology and Chief of Neurosciences Center, with a special interest in stroke and multiple sclerosis, conferred Padma Shri by President of India for the year 2016. She has initiated thrombolysis program in AIIMS, and with more than 300 publications and with past presidency of Indian Stroke Association, I invite Dr. Padma to give this talk, which is on a very important topic, that is approach to unconscious patient. Dr. M.B. Padma, please.
Thank you, sir. Thank you so much. As you said, you're my teacher, and it's an honor to be introduced by you. And thank you, National Academy, for this honor, Professor Sareen, Professor Kapil, and Professor Sood. So, boys and girls, consciousness is, being aware of yourself and of the surroundings and being able to respond to the external stimuli optimally. Whether optimally or suboptimally, you're able to respond. So when this consciousness is impaired, means you're not aware of yourself or the surroundings and are not able to respond to an external stimuli, then there are various grades of being unconscious. So I'm not going to talk about transient loss of consciousness. Let me put this on a full screen mode. Yeah. The transient loss of consciousness will be syncopes, seizures, transient ischemic attacks. So they've fallen unconscious and they're conscious again. Now, I'm not going to talk about those. I'm going to talk about those situations when an unconscious person is brought to you in the emergency. You're faced with this, this is something, I hope I'm audible. Yeah. Some technical.
Yes, you are audible. You are audible.
So there was.
You are audible, Dr. Padma, no problem.
There's an echo, sir. I'm trying to do that. Okay. So sorry about the technical glitch. So to understand when a person is brought to you in unconscious state, what this exercise will be is identify the causes and how quickly you're able to go through the spectrum of reasons why a person is unconscious and how do you manage appropriately, in the sense you have these algorithms quickly. Remember, time becomes extremely crucial when an unconscious patient is brought to an emergency. So let's come to the first one. How do I get into the next slide? Yeah. So the level of arousal in terms of unconsciousness could be several grades. It's not like all on phenomenon. Somebody's fully conscious and somebody's in deep coma, right? So there have been several, those terms which were used before, stuporose and obtundation and all those things. But then now we know that they're more of archaic terms. It's better to describe in what you see rather than just label them and stamp them into some kind of one of these terms. And remember, sleep is the only physiological form of reduced consciousness. You will all agree with me in that. So the three main reasons why a person is unconscious is because, one, there could be a structural pathology. You know that the substrate to remain conscious would be the reticular activating system, which is there in the brainstem. But it's not just that. It could be problem there, or it could be the connections and also the kind of involvement of both the cerebral hemispheres, or even in the systemic causes. So it could be structural brain lesions. It could be diffuse neuronal dysfunction, which is secondary to a whole host of systemic problems. And extremely rarely, totally down, there would be psychiatric causes. So this is a busy slide, but then let me just take you through this, that there are some very common situations, like in neurology, you have strokes and, you have ICH or cerebral node bleeds, several varieties of brain attacks. It could be metastasis and tumors wherein there is a sudden bleed into a lesion and sudden loss of consciousness, which is because of a seizure, because of status, because of, sudden raise intracranial pressure, and also lack of oxygen or cerebral blood flow as it happens in anoxic, hypoxic injury, and other reasons. And I'm not even touching trauma, because trauma is mostly in your face. Okay, we are mostly looking at the medical non-traumatic causes, and then whole host of systemic things, very commonly hypoglycemia, hyponatremia, whole lot of electrolyte disturbances out there, and also the liver and the uremic, the liver disorders causing liver failure, your kidney disorders causing uremia, and sepsis, all pervasive, there's infections. And then we have the others, like you have non-convulsive status, you have intoxications, you have the next lecture on poisoning, and then you have hypothermia, which is a temperature disorders, your neuroleptic malignant syndromes, and then you have rarer and rarer and rare causes. So just a little spectrum of what all can cause unconsciousness in a given individual. And there have been some studies, and they've looked into the epidemiology of what are the common causes, with which patients present with unconsciousness to an emergency. And they found that in a non-traumatic coma, the commonest is lack of blood supply to the brain, or there is a bleeding in the brain. Anoxic injury is the next common, poisoning, and then the metabolic. When I mean metabolic, is all this host of electrolyte disturbances, low glucose, low calcium, low sodium, sepsis, and other things. And the non-structural causes tended to be slightly outnumbered. So remember that the metabolic and systemic causes would be very, very important. Don't automatically assume that somebody's unconscious means that something which has gone structurally wrong in the brain. But when you're looking at these numbers, look at this: 3 to 42%, 1 to 39%. This is because, these are mostly a hospital base, and depends upon the geographical location, what is a kind of, like if you have a trauma center, it will all be mostly trauma. Like if you take a non-traumatic medical emergency, which is, say, a large catchment area, which is looking at all the other causes, then you have metabolic, you have sepsis and other causes. If you're looking at a neurological emergency or cardiac emergency, obviously you will have more proportion of those cases. So it depends on what your catchment area has been, and therefore there is a diversity in the reported literature. Now, there are measures to know the level of consciousness. I'm sure that you know how to make somebody, respond to your stimuli. You have these stimuli where you put in at the medial part of the eyebrow, you give a little pressure there, or with a pen or pencil, you press the finger bed. But if you have to give more rigorous and slightly painful stimuli, it would be rigorous rub on the sternum. The reason you're going to do this is the level of or the measure of severity of stimulus, starting with simple thing like a verbal, coming down to deep pressure and then the pain. And so you have the Glasgow Coma scale, which is out there, which is most frequent, which is universally used. It may have its own problems, but then it is most validated and useful, and you should know about it. Then you have the FOR score, which is probably much more objectively useful, but it is not so often used. That is a full outline of unresponsiveness. Otherwise, you can use the awake, verbal, pain, unresponsive, simple scales, or alert, confused, drowsy, unresponsive. That's far less commonly used. Before you get into GCS, you should check for factors which can interfere with your communication. All right, ability to respond and other injuries. You observe first the patient, the eye opening, content of speech, movements of right and left side. Is there an asymmetry? And then you start stimulating, first by a sound, spoken or shouted request, and then become physical by pressure on a fingertip or a trapezius or supraorbital notch. And then you rate accordingly. So this is the Glasgow Coma scale. Very simple, and most of you would be aware of that. Eye-opening, movement, and verbal. The good score is spontaneous eye-opening, obeying commands completely, and oriented. So a full score would be obviously 15. It's never 0. Now, I've seen patients, some of our students writing, it is E0, M0, V0. No. So the lowest scale would be E1, M1, V1. It is score would be 3. So according to the gradation of how the response is, you grade the severity on the GCS. This 4 score is a much more objective in the sense that it is giving you the eye response, it is giving you the motor response, it is also looking at the brainstem reflexes and the pattern of respiration. The reason this is a little better is it's incorporating the brainstem reflexes. There's no verbal component, right? And there's several studies have looked at the GCS and they've looked at the 4 score and they found good inter-observer agreement when they use the 4 score. So maybe there's a time to shift, but then GCS is still there, and this is what you should be aware of. But then when in doubt, just describe it. That is the take-home message I want to give to you. Just don't, try to fit in, your something which is round into a peg hole which is square. Please don't do that. If you're in doubt, just describe exactly what you see the patient as he or she is. History is absolutely mandatory. Many a time, the family finds the patient unconscious. The morning, the patient has not woken up, or somebody's reached home and found the patient unconscious, maybe on the floor, maybe on the bed, or on the roadside. It's a bystander sometimes who brings in, or a police who brings in the patient. So it is important to know the history. If somebody falls unconscious right in front of them, somebody, clashed the head, very severe bursting headache, and then has fallen unconscious, or had an overt seizure and now is unconscious, has seized for some time and then remained unconscious, that there is history that patient is depressed, has consumed something, is smelling of something, is a known diabetic and has had fever, has complained of some headache in the last couple of days. So all this history quickly needs to be taken from whoever has brought in the patient and also the caregiver and the family. So the time and acuity of onset, fluctuations, evolution, associated symptoms, and those things become absolutely crucial. And also such past history and the vascular risk factors. If somebody is brought in 60, 65 years old, has vascular risk factors, and other history of, say, a retroviral infection or other infections, which may tell you that there could be some kind of an opportunistic infection happening there without fever and without other, common garden variety of symptoms would suggest an infection. Family history, sudden cardiac death, anything which is similarly happening in families, suddenly they're falling unconscious. Current medication, what is the dosage of medicines that are being taken? Is there an alteration? Is there a new drug which has come in? And of course, social history of alcohol bringing, and does he take illicit drugs and other things. The neurological examination, fortunately, is brief. You can't do a 1.5 hours of neurological examination. What we don't want to miss is the level of consciousness. As I described before, you have the GCS or a 4-score. You describe in terms of your stimulus, could be verbal, physical, and then you grade the response. The pupillary responses. Ladies and gentlemen, eye is the window to the brain. And I'm going to go into a little more detail about the pupil and the eye movements. They're remarkable, and they will tell you the exact level of problem and what may be the reason behind it. So pupillary responses, oculomotor responses, the eye movements, and then the motor. When you're looking at the motor responses, you're basically looking at asymmetry and certain posturing, which I will describe a little later. Pattern of breathing. It is humongously important, that would actually quickly tell you what is the level wherein the status of unconsciousness is. Where is the level of lesion? How bad is the brain affected? The fundus becomes very important. And of course, the meningeal signs and other things, especially when there is fever there. So in an altered mental status, quickly, when I'm going to give you a little bit of case vignettes, and then we can describe the structural, whether it's supratentorial, infratentorial, and then the metabolic causes. So here is an 84-year-old lady, acute onset of drowsiness for about 18 hours. And when they did the GCS score, she was, well, E2 means she was opening eyes with deep painful stimuli. She was not verbalizing anything. And M5, essentially, she's trying to localize with a painful stimulus, not useful response. In a sense, she's not obeying commands, right? And they found that there's a gaze preference to the left, and she was moving all 4 limbs to pain. There was no asymmetry. And the CT head showed an acute infarct. If you can see that there is an acute infarct sitting there in the left posterior temporal and occipital. Now, that's an infarct in the parotoccipital area. Does it explain the status where she's not able to respond at all? Well, let us see. The unilateral hemispheric lesion will not cause a reduced level of consciousness, right? So what else? Then we did an MR, and the MR has shown a thalamic lesion. So when you have the thalama involved, so besides the brainstem, diffuse cerebral involvement, it is a thalami which are essentially important to know the level of consciousness. Impairment, involvement will be there when you have a thalamic lesion. So the stupor or coma at onset in thalamic stroke occurred in 62%. Okay, so in the sense that what it tries to tell you is, when in doubt, you need to upgrade your investigation and go on to doing a higher level of investigation. Okay. Now, the second is a 58-year-old male, hypertensive for 20 years. So that's a vascular risk factor. Sudden loss of consciousness and fall in a bathroom, followed by confusion and quadriparesis. Now, when you examined, he was drowsy. Well, he was answering a little well, but he would go back to sleep. If there's no stimulus, he would like to stay on with his eyes closed. And the pupils were mid-dilated, so sluggishly reactive to the light on the right side. The tone was raised in all 4 limbs, and the bilateral plantars were extensors. And then what is this? And when they did a CT, and they found that there is a lesion sitting in the brainstem, in the midbrain. Now, classically, these lesions could be the picture is more like a brainstem involvement, could be a big infarct there, could be a bleed there. In this case, these are actual case studies. And this actually is showing that there is a hypodense lesion on the right side of midbrain, extending into thalamus with mass effect. And the CT angiography, what I'd shown you, this is a CT angiography, which actually shows you a vertebral basilar dolichoectasia. Now, essentially what it means is that whenever such a picture is there, immediately you must suspect that there is a brainstem involvement. And the workhorse would be CT scan. And whatever the CT shows, then you either get into a vessel imaging like an angiogram. If that is not showing you, or it's not adequate to explain the clinical status as it was in the first case, go on to MR. Now, when you're looking at a pupils in an acute emergency, you use a pen light versus camera flash, you illuminate at least for 10 seconds. And the tonic pupils react slowly. If pupils are very small, ideally, You may use it lens, but I've not rarely seen people using lens in an emergency. Remember one thing, make sure that there's been no pharmacologic dilation there. You know, somebody's put drops there and it's already mydriasis. Now don't go jump into conclusion that it is a mydriasis because of something else. You have to rule out, you know, somebody putting, especially when somebody is in a hospital and from there they get referred to another hospital. Something would have been done in the first hospital. You need to be very, very careful about it. So when you're looking at a localizing value of pupillary responses, unilateral enlarged polyreactive pupils is a first sign of herniation. We call it a blown out pupil. And you actually, whenever as neurologists, you know, in critical care neurology, we actually don't wait till the pupil starts blowing out. But when an unconscious patient and you find that one pupil is blown out, herniation, immediately you need to get your imaging done and look what is it that is causing herniation of the brain. It could be an aneurysm in epicom, which has bled there, or it could be anything, but this means that there's a herniation. You can look for Horner's. That will also give you an indication. In metabolic versus diencephalic is a thalamic lesion. Now, both of them will cause small reactive pupils. It's very difficult to look at the reaction in a small pupil. For that, you need a lens. Pupillary light reflex is one of the most, you know, resistant to the responses to metabolic insults. Okay, so they would still react. So during or following a seizure, pupils may be large or poorly reactive to light. There could be tongue bite, there could be incontinence. So when a patient is coming to you in emergency and then it's lying unconscious, nobody has witnessed a seizure before. But when you see these telltale signs, it's been a tongue bite. And this been, you know, they have passed urine and clothes. That could happen even in unconsciousness because of other reasons. Again, your red flags, your antenna are up saying that maybe he's in a non-convulsive status or he had a status and now he is in the post-status state. So when you know, this is a sort of a diagrammatic display showing you that the diencephalic pupils, no, sorry about that, which showing small and reactive. Look at this. You have a unilateral blown out pupils and an uncle herniation, third nerve. The midbrain position fixed, you know, these are midbrain pupils. Pons pinpoint pupils, classically described, they're really pinpoint. And then you have pretectal, which are large and fixed, all right? So we don't want those large fixed pupils at all. Then you have a 76-year-old lady with hypertension, diabetes, sudden onset of altered mental status for last 18 hours. And the GCS is E3, B3, M5. By now, you should know what E3, B3, M5 is. And the eyes are deviated downwards nasally. Tone is again increased in all four limbs and plantars are extensor. And you're finding the CT, which shows a blown out all ventricles. Now, classically, when this is seen and the eyes are deviated downwards and nasally, it would mean that the thalami are again involved. Remember, now the case that I put forward here is something we have seen, and one of my colleagues had actually, described this because this is a rare case of sudden acute hydrocephalus in an elderly person, and this is because of an obstruction to the aqueduct. So when you're looking at a resting and spontaneous eye movements, you could have a gaze preference. So you have this patient in front of you, you open the eyes and you'll find that the gazes are there on the right side or left side. There's a gaze preference. Why? So a conjugate deviation of the eye towards the side of the lesion means same side. When it is away from the side of lesion, it is a wrong way eye. Or it could be deviated downward and nasally, or it could be vertical misalignment. One eye is up and one eyeball is down. That is Q. So when you have a destructive right frontal lesion, obviously, it's crossed, isn't it? So the right hemisphere involvement, you have a left hemiparesis and the right eye deviation because the eyes are looking towards the side of the lesion. If it's not doing that, it's a wrong way eyes. And that is usually seen in an irritative lesion. So a destructive lesion will be towards, irritative lesion will be the wrong, the wrong way or the opposite side. And the destructive right thalamic lesion, you have left hemiparesis, left eye deviation. So, that is how it is. And I just want to see if, this is where you have a lady and look at this. There is a vertical misalignment and this is a left thalamic. The eyeball is deviated downwards and medially. And you will see that there is a left thalamic bleed here. Let me play the video for you here. And can you see this? That this eye, and whenever this eye tends to go down and it goes to go down medially, this one is not going medially, this one is going medially and has a left thalamic bleed here. So the eyes are actually telling you that what could be the brain lesion. Okay. And I'm going to play another video. I don't know how many of you have actually seen this. Look at this. This is from the mid position. The eyeballs suddenly drop down and they slowly go up. That's a classical ocular bob. So there are certain of these spontaneous eye movements which you see in an unconscious patient. From a mid position, the eyeballs may suddenly go down, go up slowly, and that is bob. Remember bob, you drop, and B. So the drop is down, so that's vertical, fast down. You have a similar thing which is reverse, that's called ocular dip. So D, you go up. So that's the fast movement is up. Now, essentially what these eye movements are telling you is, you're looking at a brainstem lesion. You're probably looking at a thalamic lesion, and really it's also been described with a cerebellar lesion. So you definitely have a structural pathology out here. Now, this is an interesting eye movements, which just observe this. He's a young boy. Well, he's out of his unconscious state. He was admitted with us. Look what is happening to the eye movements. The lids flutter, and look at the eyeballs. They become chaotic. They suddenly go all around. It's just not horizontal or vertical. They just seem to go chaotic. This is a classic myoclonus in opsoclonus. So you have these pictures of opsoclonus myoclonus syndromes. In a young person, it could mostly, now this boy was a post-viral illness, but it could be a harbinger of, malignant pathology, could be one of those paraneoplastic syndromes. And an unconscious patient presenting with this, quickly you will have to understand that the pathology, most likely it is likely to be an encephalitic or a syndrome which is infective. And in a young patient, and sometimes even an older individual, it may be a paraneoplastic and would suggest that there is an underlying malignancy. Now, when you're looking at oculocephalic responses, those are basically you're moving the head and you're looking at the eye movements, right? Oculo and cephalic. So in a structural disease, it's unusual to have a normal oculocephalic response, whereas in a metabolic, a systemic reason of unconsciousness, these responses are not often impaired. But when you're deeply comatose, everything is impaired, right? So that's not the way we want to go. So quickly, when you're looking at a structural pathology in the brain, the oculocephalic reflexes are impaired. So according to, say, a pontine lesion or a medial longitudinal fasciculus, where is MLF? It is right there in the center of the brainstem. Or it could be a paramedian pontine lesion, a midbrain lesion. So in these situations, you will find that the oculocephalic reflexes are not okay and that they would not be complete or normal. Yeah, this is that patient I was talking to you about, the 79-year-old who had an acute hydrocephalus. She improved spontaneously. This was an acute hydrocephalus because of an aqueductal stenosis. So now you have a 19-year-old patient, young male, no comorbidities, headache for 2 days, 1 episode of vomiting, and came with tonic posturing, became M4, okay? M4 is bad enough, it's not even localizing, and heart rate is low, there are no meningeal signs, and CT said apparently looks normal. So what do you do here? So you quickly try and look at the meningeal signs, and then they could be meningeal signs, they could be the positivity, and the not being positive depends upon the sensorial changes again. A deeply comatose individual, you may not even find a meningeal sign positive, okay? You hear the fundus was very important. Fundus shows papilledema. Remember, CT was normal. Fundus shows bilateral papilledema. So LP was done, and in him, India ink was positive. This was a cryptococcal meningitis. And it is unusual sometimes presenting acutely, but it can happen. So you will need a high index of suspicion sometimes when you're looking at an individual, especially a young person, coming like this, and you find that there is evidence of raised intracranial pressure. There is something going wrong. It could be a structural pathology, which should be obvious on a CT scan. If it is not, then clearly there's something else. So you will need an MR You will need definitely a lumbar puncture to know what is the evidence of raised ICT. And quickly, we look at the entire spectrum of infective pathology. So a 26-year-old male, headache with metamorphopsia, basically looking at a lot of funny images, and had an operation for retinal neurocysticercosis, 1 day of irrelevant talk, agitation. And he came in agitated and subconscious state to the emergency. And so he was talking gibberish there. And again, fundus showed barahal papilledema, and you find this multiple neurocysticerci and which is there. So, but then doesn't look too bad. Why is he in this state of altered behavior? Why is he delirious? Now, because he was in a non-convulsive status epilepticus. So an EEG becomes very important to pick up a situation of unconsciousness or altered sensorium in an emergency. You may be missing out a non-convulsive status. So quickly, in these individuals wherein everything is not really fitting into your bill, I have ruled this out, I have ruled that out, everything seems to be okay. Why is this guy still in an unresponsive state? Please get the EEG done. Okay. Now, the next is an 83-year-old gentleman. He has an atrial fibrillation. He's been on a newer anticoagulant, apixaban, and he had a right parietal subdural hematoma. So, he had a traumatic fall, so an SDH, and there was some diffuse slowing, and there was, focal kept on having seizures. And then he became stable. He was discharged with, a bunch of anti-epileptic drugs. Then he came back. He had reduced level of consciousness. His consciousness level dipped further. CT was done. There was no change from the earlier one. And the EEG was showing total slowing altogether. Then you do a metabolic screen. The ammonia was pretty high. Remember, when the ammonia level is more than 75 micromoles per liter, that's when you develop an encephalopathy. This is true even for hepatic encephalopathy. Most of the hepatic encephalopathies are seen when the ammonia level are between 150 to 200. So less than 75, they are okay. So this guy has almost 200. So what are the drugs causing hyperammonemia? Please remember, especially in an elderly individual, in fact, any individual, look what drugs are being taken. Any new drug which has been introduced, valproate does cause hyperammonemic status. So when you have valproate out there, look at all the drugs and then look at the reason for maybe there is a toxicity or development of hyperammonemia, which will again explain why there is alterations in sodium. So in the lab investigations, in the metabolic screen, you start with sugar, such a simple test. A random blood sugar, a point of care system you have in most of the emergencies, quickly do that. 1 minute, you should be able to get. Look at the acid-base gas analysis. So many times you get an ion gap. There is acidosis. It would explain to you why the person would be in an altered sensorium. ECG, obviously CBC, LFT, RFT, the serum electrolyte tox screen, which you'll have a wonderful lecture after this. You'll be hearing about the poisoning as such, and a chest X-ray. So these are very quick investigations which are available at the most district hospital levels. There's no reason why you should not do that. So let's now look at another case. 88-year-old gentleman, hypertensive, admitted to medicine with a low-grade fever. And 6 hours after admission, he became incoherent, agitated, confused. Got the electrolytes, they seem to be normal. And then the urine was sent, the culture, you're going to, what is this? He is an elderly gentleman, came with fever and became delirious. So a delirium is a change in the attention, awareness, cognition. They become agitated. There is an increase or there is a hyperactivity. All right. So why is a delirium occurring in this individual? The failure of attention, distractibility, failure to focus. Patients in an early metabolic encephalopathy may be in that. In fact, when we look at hepatic encephalopathy, uremic encephalopathy, in the earlier stages, they're delirious. When things don't get controlled, then they go into deeper in stages and they go into deep coma. And they may have hallucinations. Their altered sleep-wake cycle is one of the earliest signs with which they can have. And so all these are neurocognitive syndromes. They look altered, so they look demented. So what are the precipitating factors for delirium? In a lot of patients, it's infection. I know in my own personal experience, you have this elderly individuals, no fever, nothing, And the caregivers would say, for the last 40 to 72 hours, this guy is talking gibberish. He suddenly has become demented. And when we examine, he's actually delirious, no fever. And then we actually see that either they have a urinary tract infection. Couple of cases, we actually found pneumonia. So a lot of times it is just infection in an elderly individual, which they become beclouded, and that could be delirious or just simple state of altered sensorium and they're going into unconsciousness. In that, there are several series where they found that there is infections, either lung or the UTI were the most common infections. So please remember, especially in an elderly individual, polypharmacy, what is the new drug in, and also for a lot of times they're not sleeping. So you introduce a new drug and say that, this would help them sleep. Especially there are drugs like lorazepam, and then they sleep for next 48 hours and they're brought in a state of unconsciousness to the emergency. Drugs and antipsychotics, antidepressants, and sleep medicines are very, very important to look into. Then you have a 15-year-old male, acute onset progressive drowsiness, about 2 to 3 days, and then he was found to have this E2, V2, M5, small reactive to light pupils, small breathing. Remember. So moving all four limbs, reflexes are brisk. There is some terminal neck rigidity, is dehydrated, and the blood sugar 490, ketone bodies are positive. So what do you have here? You actually have diabetic ketoacidosis. So when you're looking at the pattern of respiration, there are several varieties. You have Cheyne-Stokes, you have central neurogenic hyperventilation. You progressively go down as the brainstem is involved. You have Bowers breathing and then ataxic breathing. So the Cheyne-Stokes respiration, it requires an intact brainstem function. So it is generally seen in when there's a bilateral hemispheric diffuse dysfunction. And here, normally the drive is when the PCO2 rises. And in these situations, when there is a delay in the blood supply going into the cerebrum as such, you have these sensory reactions very sort of limited. It doesn't respond much. Respiration slows, ceases. Then the hypercapnia picks up a lot, and then suddenly there is a waxing and waning of breathing, which is called Cheyne-Stokes. So it's a periodic breathing. Whereas on the Kussmaul breathing does point towards metabolic cause. There is a deep, slow, rhythmic breathing because of low blood pH and deep respiratory efforts and compensatory respiratory alkalosis. Then you have a 21-year-old lady, pallidopyramidal syndrome, extrapyramidal syndrome, fever, drowsiness, came in with unconscious state. What did you find? You found that the whole body is stone is rigid, plantar subflexor. Syndopa was stopped for last 2 weeks and the CPK was 10,000 and a raised LDH. What are we dealing here with? Neuroleptic malignant syndrome. So again, a drug. So in a known patient who's been on antipsychotics, be very, very careful about the presence of a neuromalignant syndrome. CPK would give you the answer to it. So in a diffuse metabolic encephalopathy, you can have a Gegenhalten phenomenon. There would be sort of rigidity, and they would sort of, impede your maneuver to move the body. And as patients become more stuporous, muscle tone tends to decrease and other forms of rigidity become apparent. So you can find that there is a decerebrate rigidity, which you see in M2, and you have a decorticate, which is a shade better. I would say that nuance is hardly of any importance to me, but then better than decerebrate. The more important responses would be M4, where they are not decorticating. And then M5, where they're trying to localize, and the best is obviously M6. Now, some of the last cases, I'm sure you're getting bored now. 36-year-old male alcoholic, sudden bilateral loss of vision. He was on a flight, he landed and he lost his vision. And there was sudden seizures and he was brought in a state of E1, V1, M1. CT had normal. Anion gap 20.9. What did he do? He consumed illicit liquor just before boarding. So a methyl alcohol poisoning, that would be important. And we'll talk about, I'm sure you'll be discussing that in the next lecture. Now, then there is this extremely small percentage, and I will never tell you go into psychiatric causes in the first place. But when you have a young person and it's not really fitting into the bill, then you may have some maneuvers to say that why is this person lying unconscious? So you have the Hoover sign. You have this, just raise up the hand and let it fall on the face. Unconscious patient would fall anywhere, but a person who's feigning it, won't let it fall, and it will go anywhere, here, there. And we've actually seen it in our wards. So there are ways to distinguish that as well. See, there have been some studies which looked into these etiologies of altered mental status in an emergency, and they found that largely systemic, stroke a big number, toxicity huge number, metabolic and systemic are the most important, and obviously psychiatric is hardly 1%, 1 to 2%, and others you have seizures, infection, but still undetermined is 7.1%. So the pupils, small pupils, less than 2 mm, opioid toxicity, pontine lesion, mid-sized pupils, midbrain, which are unresponsive to light, maximally dilated pupils, drug toxicity, and mixed dilated pupils, the oculomotor nerve lesion from inertia when it is unilateral. And the pattern of breathing, Kussmaul respiration is more of metabolic, like you see in diabetic ketoacidosis, shallow with an extremely depressed respiratory rate seen in opiate overdose, ataxic breathing, Barrett's respiration when you have this in the lower pontine lesion, central neurogenic hyperventilation, deep breathing, they're deep and they're very, very regular, which is seen in a pons or a midbrain lesion, Cheyne-Stokes, where you have apnea and then hypernia, then alternating. So what could be done at once, which is fatal? Patient is unconscious. I am there in the emergency. What could be immediately fatal? Cardiac arrest, airway obstruction, breathing, ABC. So please look at the pulse. Pulse there, no pulse, no heartbeat, obviously cardiac arrest. Then you get into that. Airways, is he breathing? Is the oxygenation? Quickly put in the, saturation probe, look at it. So this 3 would be at once fatal. What could be fatal in the next few minutes? Hypoglycemia, overdose, intracranial hypertension and herniation. Quickly, when you have your ABCs out there and that is an ongoing parallel, you quickly do the blood sugar, look at the overdose, take the history, and you can smell, you can look at the pattern of breathing and look at the pupils, the ocular movements, and decide. So in a neurological examination, pupils, eye movements, is he moving all 4 limbs? Is there any asymmetry? Signs of impending herniation, is there hypertension? Is there bradycardia? Irregular respiration? Posturing, dilated pupil, breathing pattern, is it regular? Is it Cheyne-Stokes? Is it irregular? Is there apnea? Toxidrome, I'll come to, obviously you'll find that in the next lecture. Signs of shock, skin, warm, cold, obviously again, blood pressure. Trauma, not all the time you'll find signs of trauma. Not all the time you'll find the police guy coming with a road traffic accident. Sometimes they just fallen on the road, or they may be even fallen at home. They may be taking anticoagulants and the simple form may cause issues. So look at for trauma, abdominal. Now, what could be fatal in the next 10 minutes? Still the ABCs, but then look for hypotension, anaphylaxis, hyperkalemia, acute MI, aortic disasters. And the next few hours, stroke, ICX, sepsis, alcohol withdrawal status, metabolic encephalopathies, and whole host of other situations. So summing up, step 1, ABC, vitals and blood sugars. Step 2, history. I would say it's nothing like steps. These are all running parallel. Examination, your baseline investigations, which I had given you earlier. Structural imaging as you assess on the way, lumbar puncture, and then get your metabolic, your serum ammonia and everything else, and your EEG, and so on and so forth. So the initial investigations, full blood count, blood glucose, urea electrolytes, calcium. This is what is sometimes maybe ordered at times, but I would say a liver functions, clotting screen, toxicology, chest x-ray, ABG, which is right on top, I should say, cultures and other
Dr.
things.
Padma, I've been asked to...
Yes, sir. I think that's it. Thank you.
Okay,
I'm
right.
so sorry.
Thank you. So, because there is another session and there may be some questions from the audience. Yeah, I think with this wonderful session, we should have some questions. Those who are listening, they should certainly have some questions. If not, let me just give you some pearls, which already Dr. Padma has highlighted, that as soon as you see a patient, if you do blood sugar, you will diagnose some patients what is the cause of coma. So I think that's one thing after ABC which must be done. She has already said, but let me re-emphasize If you see elderly person and he has altered sensorium, think of sepsis, hyponatremia, drugs. These are the common, unless there is a structural cause which will be evident in CT scan. And if there is young person who was all right last night and has come unconscious, very likely this is a case of poisoning. I think that will be dealt with in the next session. In the meantime, any other question?
I have firstly compliments Dr. Padma for this very simplified and focused lecture. Sometimes when a patient comes to us, especially in the liver hospitals, we are worried that if we move a patient for a CT or an MR, there could be a kind of problem in the brain or midbrain. So would you recommend that there should be, while we are taking a patient from emergency to the ICU, should we do a CT or an MR? And what should be the position of the patient before we take up the patient for imaging?
Thank you, sir. So one is that we are looking at a non-traumatic patient. In trauma, the posture as well as the transport things are different algorithms. In a non-traumatic patient, the patient is unconscious in front of us. So what we need to prevent is an aspiration. So positioning will be important to prevent aspiration. And we're looking at an ABC and the airway, the breathing, oxygen is impaired, then you will have to intubate. You have to ensure that oxygen saturation is maintained. You have an IV access in there and your blood pressure is okay. Transporting someone who's completely hypotensive or whose saturation is fallen to anywhere will be totally hazardous. So, and you have to secure those lines before you transfer the patient to either to a critical care unit or en route to whether you need an imaging or anything. So I would say ensuring that the patient does not aspirate and maintain that the breathing, oxygenation, and as well as your lines in secure to maintain the blood pressure and saturation.
Second part is, would you prefer, let's say, to do an MR or a CT for patients who have some, epilepsy or who have seizures? Because these patients who have seizures.
We are not able to hear you, sir.
So, sir is asking, sir, whether in a patient with hepatic encephalopathy who presents with seizures, what are the precautions that you need to do? Whether you need to do a CT or an MRI. So I would say, sir, that in hepatic encephalopathy or in an encephalopathy, whether it's type A, type B, or type C, and you have a liver failure or whatever, that you have patient who's gone into encephalopathy and who's come with seizures or a myoclonus or any of those features, in that situation, a CT is the first one. My workhorse would still be CT because I would still happily rule out a bleed. Now, there are a lot of times a patient who's getting dialyzed and has suddenly started a dip in sensorium and has a seizure. A simple CT would tell me the subdurals. So after that would be an MR. So an MR would be a beautiful investigation. Otherwise, you can do it in 6 minutes flat, but it has its own challenges. So I would say workhorse is still the plain CT. So will you agree with me, sir, on that?
Yes. I would go one step ahead and say MR has very limited role. CT scan solves the problem most of the time. MR is only to confirm brainstem or posterior fossa lesions, which were maybe missed by CT scan, but that confirmation is rarely required. We can make it clinical diagnosis. I think the next session is very much now going to be on. I'm told that the chairperson of the next session has some engagement, and therefore we need to start early. So maybe if there are no questions, thank you, Dr. Padma. Excellent presentation.
You, sir. Thank you.
Thanks a lot.
Thank you for being there. Thank you, sir.
And now I hand over to the organizers for the next session.
The ma'am said that we will introduce the speaker.
Thank you, ma'am. Now I'd like to invite the chairperson for the next session, Professor Meenu Singh, ma'am, who is the Executive Director and CEO of AIIMS Rishikesh. She has been trained as a pediatric pulmonologist at the Children's Hospital, University of Pittsburgh, USA in 1994 to 95. And since then, she has been working in the field of pediatric pulmonology at the Advanced Pediatric Center, PGI Chandigarh. And she had also been the head of the Telemedicine Center, now designated as the Department of Telemedicine at PGI. And she had been in charge of the Regional Resource Center and National Knowledge Network at PGI. And she's also a member of the Steering Coordination Committee for Telemedicine and E-Learning of Ministry of Health and Family Welfare. I request ma'am to kindly introduce the speaker of the next session. Over to you, ma'am.
Thank you very much, Priya. And thank you very much for inviting me for this particular session. I would like to introduce Dr. Praveen, who is going to be speaking, who is actually the professor of emergency medicine at All India Institute of Medical Sciences. And he's going to be speaking on common poisonings. He's been trained in USA through a WHO fellowship for toxicology. I request Dr. Praveen to take over, please. We know that poisonings are of different types. They could be accidental, they could be intentional, they could be suicidal, or they can sometimes be homicidal. So there are a lot of medical legal aspects of poisoning. But today, I think we're going to focus more on the pharmacological effects of poisoning.
Along with the team, I'm looking forward to the opportunity providing the highest level of safety and service that Vistara is proud of having. Weather forecast will be good. For your safety, recommend that you always keep your seatbelts fastened while seated. In the meantime, we invite you to enjoy the new feeling of flying with Vistara. Thank you very much.
Thank you, madam. So I'm going to talk about managing a patient with acute poisoning. And as you know, acute poisoning would carry a high mortality and morbidity, particularly in Indian setting. If you see figures from India, it's one of the leading causes of death in patients who are younger than 35 years age. Trauma being the most common cause of death in patients who are younger than 35 years age. If you see the figures from UK and USA, the most common substances which are involved in poisoning are analgesics and sedatives. But if you see the figures from India, the most common causes are the pesticides. And these are the common causes of poisoning in India. You have organophosphates, carbamates, aluminum phosphide, your organochlorines, rodenticides, and corrosive agents. In southern part of India, you have plant poisoning also, which is very common. If you see the data from the National Crime Records Bureau in 2021, after the traffic accidents, which constitute about 44% of the cases, the poisoning constituted about 6% of the cases. In 2020 and 2021, the most common mode of suicides were the hanging, about 44%. But the second most common mode of suicides were poisoning. That is about 25%. Roughly 1/4 of the causes of suicide were poisonings. So a patient with acute poisoning can come with many presentations. They can come with acute gastroenteritis, can come with altered sensorium, can come with seizures, acute liver failure, acute kidney injury, can come with cardiac arrhythmias, hypothermia or hyperthermia, can come with respiratory depression, can come with sweating, they can come with pupillary changes, can come with metabolic acidosis. One of the important things to remember is that they can come with trauma also. So remember, a patient who comes with trauma always suspect poisoning also in these patients. So when a patient comes with acute poisoning, you have to follow certain steps to manage these patients. So number one, you want to reduce the exposure to the patient. For example, if the patient is exposed to a gas, remove the patient from the source of exposure. Second, you want to resuscitate and stabilize the patient. Third, you want to diagnose the type of poison by history, by examination, and by simple lab tests. Number four, you want to reduce absorption of toxin from the gut by various GI decontamination methods. Number five, you want to increase elimination of toxin from the body. Number six, you want to use some certain antidotes, which are the specific treatment. And number seven is the supportive treatment. Now remember, these are not the sequential treatment, sequential steps. These are to be done concurrently. Now, a patient with acute poisoning can come in cardiac arrest also. So in these patients, you have to follow the steps of the ACLS, but with certain modifications. You have to add certain additional steps beside the ACL steps. For example, if you have certain antidotes available to you, you can use them in these patients with cardiac arrest. For example, if the patient ingested organophosphates, you can give atropine. If the patient is bitten by a snake, you can give snake antivenom. If the patient has ingested digoxin, you can give digoxin fab fragments. If the patient has taken antidepressants, you can give sodium bicarbonate. In patient with a calcium channel blocker or beta blocker poisoning who has come in cardiac arrest, you can give high doses of insulin with dextrose. In local anesthetic-induced systemic toxicity who have come in cardiac arrest, you can give intravenous lipid emulsions. In addition, you can consider other therapies also, like with pacemaker, intra-aortic balloon pumping, and even extracorporeal membrane oxygenation. Important to remember in these patients is that these patients are often young without any pre-existing cardiac illnesses. So these patients often require prolonged CPR, prolonged cardiopulmonary resuscitation, maybe for 1 hour, 2 hours also at many times. If the patient is not in cardiac arrest, then you need to follow the standard ABC steps, that is the airway, breathing, circulation. But if the patient has only external decontamination with a chemical, then you have to perform external decontamination only. But just remember, you should not get exposed yourself. So just prepare yourself with personal protection equipments and then decontaminate the patient. So A is for airway. So in general, we say you assess the patient by bedside estimation. And in general, if a patient has a Glasgow Coma scale of 8 or less than 8, we must intubate the patient. And one of the questions asked by Professor Sareen was that in case we want to move the patient from one area to other area, then we must intubate the patient if the Glasgow Coma scale is then less than 10. But otherwise, we must intubate the patient if the Glasgow Coma scale is 8 or less than 8. If the patient has history of is in altered sensorium, we must stabilize the cervical spine while intubating the patient because the patient might have undergone a trauma also. If the patient is not a moribund, not very sick patient, then while intubating the patient, we prefer what is known as rapid sequence intubation, in which we prefer to give neuroparalytic agent. And for that, we prefer to give rocuronium and not succinylcholine, because succinylcholine is contraindicated in patient with organophosphate, which is the most common agent in an Indian setting, in patient with digoxin poisoning, in patient with cocaine poisoning. An important issue is that in patient with caustic corrosive agent poisoning, who ingest corrosive like acid or alkali, carefully examine the oropharynx for any injury, and also auscultate the chest and neck for any stridor. Now, these patients may have oropharyngeal injury, and if you miss it, these patients may develop edema because of oropharyngeal injury. And suppose you miss it, these patients are going to develop edema over a period of time. And if you miss it, and these patients suppose later on require intubation, it will be really very difficult later on. B is for breathing. Obviously, if the patient is not maintaining saturation, despite giving oxygen, then the patient will require ventilatory support after intubation. In patient who has taken hydrocarbon like kerosene oil, the chances of aspiration are very high. Again, the patient may require ventilatory support. In patient who have taken opioids, particularly heroin, or patient who have taken aspirin or salicylate, these patients can develop acute respiratory distress syndrome. And again, the patient will require ventilatory support. C is for circulation. If the patient is hypotensive, the first thing is to give a bolus of saline to maintain the blood pressure. In case the blood pressure is not maintained with a bolus of saline, after that you can give a vasopressor like norepinephrine. In patient with aspirin poisoning, important thing is to maintain the volume, because these patients would require volume maintenance, because these patients will require administration of sodium bicarbonate to increase excretion of salicylate from the urine. And for that, volume replacement is required to be given. Now, it is important that you should not keep on giving fluid to the patient with the hope that toxin gets excreted from the kidney in increased amounts. Now, that is a wrong perception. This was known as forced diuresis, that you keep on giving fluids to the patient in large amounts with diuretics like Lasix. Now, that is a wrong assumption, that you give large amount of fluids to the patient, give diuretics, and this is going to increase the amount of toxin from the excretion of toxin from the kidneys. So that is a very long perception. This may be harmful to the patient. So do not give large amount of fluids to the patient with the hope to increase the excretion of toxin from the kidneys. Now, in patients who have taken beta blockers and calcium channel blocker overdose, very carefully give fluids to the patient, because these agents are negative inotropic effect. They can produce myocardial depression. So if you give large amount of fluid to the patient, it can cause heart failure. In patients who have developed cardiac arrhythmias because of the overdose, do not give antiarrhythmic drugs as the first-line agents. The first-line agents are the correction of hypoxia, correction of electrolyte disturbances, correction of acid-base disturbances, and then use of antidotes. If it is not, these are not effective, only then give antiarrhythmic drugs. For QRS interval prolongation in the ECG, the drug is sodium bicarbonate. If there is a QT interval prolongation, the drug is magnesium sulfate. D is for disability, that is control of seizures and use of drugs in patients with altered sensorium. The best drug for controlling toxin-induced seizure is one of the benzodiazepines, that is diazepam, lorazepam, or midazolam. The second drug is, if the seizure not getting controlled with benzodiazepines, the second drug is the phenobarbital or propofol. Phenytoin has no role in toxin-induced seizures. I repeat, phenytoin has no role in patients with seizures because of toxins. Only in one toxin, that is isoniazid, that is INH, where there is a role of vitamin B6 or pyridoxine. Also exclude hypoglycemia and hyponatremia as the cause of seizures. D is for the drugs which can be given in patients with altered level of consciousness, which are dextrose, naloxone, thiamine, and flumazenil. You can see a red flag in front of flumazenil. We'll discuss that. Now, dextrose, Dr. Padma talked about dextrose, in that hypoglycemia can cause altered sensorium. And hypoglycemia is a great mimicker of, it can cause altered sensorium, it can cause stroke, it can mimic stroke also. And many drugs, many toxins can cause altered sensorium and hypoglycemia. Insulin, oral anti-diabetic agents, alcohol, particularly in children, salicylates, and quinine. So whenever a patient comes with altered sensorium, always check blood glucose level by bedside estimation of dextrose, of glucose. So if the blood glucose is less than 80 milligram per deciliter, or patient has hemiplegia or any focal deficit with blood glucose less than 100 milligram per deciliter, or by chance you don't have a rapid blood glucose estimate not available to you, then all patients with the altered sensorium should get hypotonic dextrose intravenously. If because of some reason you are not able to get IV line, you can give glucagon subcutaneously. The third drug for hypoglycemia is octreotide, particularly if hypotonic dextrose is not able to control hypoglycemia. The second drug which can be given to a patient with altered sensorium is naloxone. If the patient is having altered sensorium with pinpoint pupils or with respiratory depression, you can give naloxone to the patient. The initial dose is 0.1 milligram, unless the patient has respiratory depression, when the dose is 2 milligram. If the patient does not respond to 1.1 milligram dose, the subsequent dose is 0.4 milligram to 2 milligram, and this can be repeated every 2 minutes to a total of 10 milligram. The third drug in a patient with altered sensorium is thiamine. Now, thiamine is basically was used thinking that Wernicke's encephalopathy can be a cause of altered sensorium. But the reports have suggested that Wernicke's encephalopathy is a very rare cause of altered sensorium in emergency departments. Secondly, if you give empirical thiamine, it can cause anaphylaxis in many patients. So now it is recommended that thiamine can be given in patient with altered sensorium only if you think that patient is probably an alcoholic or is malnourished. Otherwise, thiamine may not be given empirically in all patients with altered sensorium. The fourth drug, which is flumazenil, which can be given empirically in a patient with altered sensorium. Now, this drug came with a bank that if the patient recovers after giving flumazenil empirically, obviously the patient would not require a CT scan or a lumbar puncture. He will not require anything after that. No intubation is required. But the problem came later on that if the patient had ingested something like tricyclic antidepressant, carbamazepine, he may develop cardiac arrhythmias, may develop seizures after giving flumazenil. Or if the patient was taking chronically benzodiazepines, he may develop withdrawal after giving flumazenil. And this may be life-threatening. So at present, flumazenil is not recommended to be given empirically in a patient with altered sensorium. So this is out nowadays from a patient with altered sensorium, where the history is not known at all. E is for electrocardiogram. So all patients with poisoning, electrogram should be done in these patients. It can show associated electrolyte disturbances like hypokalemia, maybe hyperkalemia. It is a very good screening test for tricyclic antidepressant poisoning. It is also useful in digoxin poisoning, in organophosphate, aluminum phosphate poisoning. In cocaine poisoning, it can show myocardial ischemia or myocardial infarction. Now, if you see this ECG, this is a very classical of tricyclic antidepressant poisoning. It shows tachycardia. There's an R wave in lead AVR, and there's a widening of QRS complexes. Very typical of tricyclic antidepressant poisoning. So if these changes are not present, the QRS duration is less than 100 milliseconds, it is not widened, the risk of toxicity in terms of seizures and cardiac arrhythmia is very, very low, except in case of amoxapine, which can cause seizures without widening QRS complexes. Digoxin, you know that in therapeutic doses, it causes SC depression and T wave inversion. But in toxicity, it can cause any arrhythmia except for tachycardia. It can most often causes ventricular premature contractions. And this is typically shows atrial tachycardia with 2:1 block. F is for physical examination. Now you want to know what kind of toxin the patient is ingested by eliciting history from the patient or from the patient relative and examining the patient, particularly emphasizing on the vitals, on the pupillary size, on the pupillary reaction, on the skin, whether it is dry or wet, on the bladder, whether it is full or empty, and the bowel sound, whether they are hyperreactive or they are reduced. Based on that, you can define a toxidrome, which is cholinergic, anticholinergic, sympathomimetic, opioid, or sedative hypnotic. So cholinergic toxidrome is the commonest toxidrome which is seen in our country, because we have the commonest is the organophosphate and carbamate poisonings, which are seen in our country. It can also be seen with some mushrooms, and of course with chemical warfare agent like sarin and somans. Now, the organophosphate and carbamate, they produce three types of effects, that is muscarinic, nicotinic, and CNS effects. The muscarinic effects can be remembered by the mnemonic dumbbells, that is diarrhea, urination, meiosis, bronchoria. The bronchoria means increased secretion in the lungs, bronchospasm, bradycardia, emesis, low blood pressure, that is hypotension, lacrimation, and salivation and sweating. Now, these three, which are shown in the red, are the three killers: bronchoria, bronchospasm, and bradycardia. The nicotine effects are the muscle weakness, fasciculations, and respiratory muscle paralysis causing respiratory failure. The CNS effects are the confusion, coma, and convulsion, the three Cs. Now, cholinesterase levels, which are the enzymes, which are they are helpful in the treatment, in the diagnosis, but not in the management. The most important antidote is atropine. The pralidoxime or PAM is most people don't use it, so role is very, very controversial. So, if the initial assessment of the patient reveals that patient has meiosis, has excessive sweating, has bradycardia, low blood pressure, and bronchoria, bronchospasm, or chest auscultation, the patient would require atropine. If these 5 parameters are not there, then the patient would require observation for at least 12 hours in the emergency department. The initial dose of atropine is 1.8 to 3 milligram intravenously, and give oxygen along with that. After 5 minutes of giving atropine, assess those 5 parameters of cholinergic poisoning, particularly the pulse rate, the blood pressure, and chest on auscultation. Also assess the axilla for any sweating and the pupils for the size of pupils. After 5 minutes, if there is no response in these 5 parameters, double the dose of atropine and again assess these 5 parameters after 5 minutes. If there is no response, again double the dose after 5 minutes. So, for example, if the initial dose is 1.8 milligram, after 5 minutes, double the dose to 3.6 milligram. Again, after 5 minutes, double the dose to 7.2 milligram. And keep on doubling the dose every 5 minutes till you get the target points, which are the chest is clear on auscultation, there is no bronchoria, bronchospasm, the heart rate is more than 80 beats per minute, the pupil are no longer pinpoint, the axilla dry, that is no sweating, and the systolic blood pressure is more than 90 millimeter mercury. After that, calculate the total dose of atropine given to the patient. Suppose it is 20 milligram. Now add that, about 10 to 20% of that is added in the normal saline. So 20 milligram, 10% will be about 2 milligram. So add that in normal saline and give 2 milligram every hour. Observe the patient every 50 minutes for underdosing or overdosing of atropine. And along with that, give normal saline because patient has lost a lot of fluids in terms of lacrimation, salivation, diarrhea, urination. Okay, let's have a case who is a 34-year male found to be confused, delirious, tachycardic, the blood pressure a little high, he is alert but disoriented, the pupils are dilated, blood sugar is normal, so possibility of ethanol or drug withdrawal was thought of, a CT was planned, but at this stage, the temperature was found to be very high, the face was bright red, the mucous membranes were dry. So this is a case of anticholinergic toxidrome, which can be produced by atropine, tricyclic antidepressants, phenothiazines, antihistamines, anti-Parkinson drugs, and datura. So the patient would have dry flushed skin, dry mucous membranes, mydriasis, that is dilated pupils, reduced bowel sounds, retention of urine, tachycardia, mild hypertension, cardiac arrhythmias, raised temperature, confusion, delirium, and seizures. The treatment is very simple. For agitation, delirium, and seizures, the treatment is one of the benzodiazepines, but avoid phenothiazine like haloperidol, which can reduce the seizure threshold. For wide complex tachycardia, the treatment is given sodium bicarbonate. For ventricular dysrhythmias, try lidocaine. If not successful, you can try amiodarone, but avoid procainamide, which can prolong QT interval. For torsades, D-point, which is often because of QT interval prolongation, give magnesium sulfate or try overdrive pacing. So we have a 28-year-old man arrested for possible smuggling of drugs. He was agitated and sweating. The pulse was 140 per minute, really tachycardic. Blood pressure very high, 220 by 130. Temperature was 39.6 degrees Celsius. Pupil were dilated and reactive. Skin was warm and diaphoretic. So this was he was managed in the emergency department. An X-ray abdomen was taken, and you can see in the large intestine there was packets visible. You can see the whole large intestine full of packets. So this was a patient of body packet syndrome with rupture of one of the packets causing sympathomimetic toxidrome, which can be produced by amphetamines, cocaine, phencyclidine, and energetic decongestants. The patient would present with CNS excitation, seizures, hypertension, tachycardia, sweating, dilated pupils, hyperthermia. And you can note that these features similar to anticholinergic poisoning here. The difference here is that the patient would have dry skin in anticholinergic poisoning. Here the skin is sweaty, that is wet and sweaty. Secondly, the skin, there's no urine retention in the sympathomimetic poisoning. The treatment again is IV fluids and external cooling. For chest pain, hypertension, and for seizure, the treatment is mainly one of the benzodiazepines. If the blood pressure is not controlled, you can give nitroglycerin and labetalol. For removing drug packets from the intestines, whole bowel irrigation is one of the most important methods in these patients. A 20-year-old male patient presented with altered mental status. Respiratory is 8 per minute, shallow, saturation 82%, pulse rate is 60, blood pressure 90/60, chest is clear, pupils are only 1 millimeter, very small, Glasgow Coma Scale is 11/15, blood sugar is normal. So this patient has a respiratory depression, which is shallow also, with bradycardia, with small pupils. So this patient has opioid toxicity, opioid toxidrome, which can be caused by opium and synthetic opioids like pethidine, heroin, morphine, codeine, pentazocine, tramadol, and it can cause respiratory depression, hypotension, coma, and meiosis. In heroin overdose, it can cause acute respiratory depression, acute respiratory distress syndrome. With tramadol, propoxyphene, and pethidine, seizure can occur. In tramadol, which is very commonly used nowadays, there can be hypoglycemia and acute liver failure. Now remember, pinpoint people cannot be present in some cases. It may not be present with pethidine overdose, with propoxyphene overdose, and pentazocine overdose. And in severely poisoned patients who are hypoxic, the pupil may get dilated. The treatment is naloxone. Now, also one remember that with pethidine overdose, you can also develop what is known as serotonin syndrome, particularly when the patient is taking SSRIs or MAO inhibitors, or sometimes with dextromethorphan, which is very commonly used cough suppressant. Patient with serotonin syndrome would have severe hyperthermia, muscle rigidity. They would also have hypertension, tachycardia, and altered sensorium. So this is a 25-year-old female who is symptomatic for last 18 hours with some diarrhea, insomnia, abdominal cramps, sweating, agitation, and piloerection. She has some mydriasis or dilated pupils, mild hypertension, tachycardia. So this is a withdrawal syndrome, which can occur with benzodiazepines, alcohol, cocaine. And the treatment is to give one of the benzodiazepines again. So we finished F, now we go to G, that is gastrointestinal decontamination. Now the recommendation is that the procedure for gastrointestinal decontamination should be done in those patients only who have come to you within 60 minutes of ingesting a life-threatening agent. Now this is not possible in most of the patients who come to us in Indian setting. So what you can do is you can consider 3 factors. Is the injection potentially dangerous? Number 1. Number 2, can the emptying procedure which you have done or which you are going to do can remove significant amount of toxin from the gut? And number 3, do the benefits outweigh the risk of the emptying? Now, for example, if the patient has taken a non-toxic amount of a non-toxic agent or a non-toxic amount of a toxic agent, or has come to you after a significant, after passing, maybe after a delay of 2 or 3 hours of ingesting agent, or has a repeated vomitings after ingesting agent, there's no point in doing a gastrointestinal decontamination. Or if patient has taken a corrosive agent or a hydrocarbon, the risks are more than the benefits. The patient can develop gastric perforation or can have aspiration. So therefore, you may not do a gastrointestinal decontamination in these patients. Now, syrup ipecac was very commonly used previously, but it's not recommended nowadays because there are several limitations. Gastric lavage is one of the most commonly used gastrointestinal decontamination procedure. It may be done if the patient ingested a life-threatening toxic within last 1 hour or so, and the agent is not bound by activated charcoal. So in this, a large bore orogastric tube is passed into the stomach, and then aliquots of tap water in adults and saline in young children are given. And then maybe every 15 minutes, the aliquots are given and they are removed. In patient with altered sensorium, always intubate the patient before doing a gastric lavage. The position of the patient should be left lateral position, not right lateral position, as shown in this figure. It is contraindicated if the patient has unprotected airway, patient has ingested a caustic agent, or patient has taken non-toxic agent or rapidly absorbed agents or hydrocarbons, unless the hydrocarbon contain a toxic agent like pesticides. Now, never do a gastric lavage just as a punitive action to the patient, because this can lead to gastric perforation, can cause aspiration. This is the activity charcoal is the most important gastrointestinal decontamination procedure. It absorbs toxin on its surface. The dose is 1 to 2 kilograms per kilogram of body weight. Only a few toxins do not get absorbed to the charcoal, which are lithium, iron, cyanide, and alcohols. It is contraindicated in corrosive agents and presence of ileus. Multiple doses of charcoal can be given in patient with theophylline, phenobarbital, aspirin, and carbamazepine poisoning, but avoid giving multiple doses of cathartics in these patients because this can lead to dehydration and electrolyte disturbances. Whole bowel irrigation is a procedure in which we give 1 to 2 liters of polyethylene glycol solution every 1 hour orally, and this mechanically washes the gut. So everything comes out from the rectum. It is useful when the patient has taken drugs which are not absorbed by the charcoal, like iron, lithium, drug packets, and lead. It is contraindicated when the patient has ileus or intestinal obstruction. H is for help. Now you can consult a toxicologist if somebody is available, or you can consult the National Poison Center or the Regional Poison Center. H also reminds you to take rectal temperature in case of altered sensorium to check for hypothermia or hypothermia. I is for enhancing excretion of the toxin from the body by multiple doses of activated charcoal. Again, no role of forced diuresis in patient with acute poisoning. You can change the urinary pH to alkaline side by giving sodium bicarbonate. Very limited role, only in very few toxins like salicylic acid, phenobarbital, and 2,4-D. Only thing you have to replace potassium very frequently in these patients. You can use hemodialysis in a certain poisonings like aspirin, lithium. Methanol is important here because many patients with methanol have delayed toxicity, and these patients can be put on hemodialysis. Patient with phenobarbital, patient who develop acute kidney injury following poisoning will also require hemodialysis. You can have some lab tests to diagnose the type of poisoning. For example, you can examine urine to look for the crystals in patient with ethylene glycol poisoning. You can see these crystals, which are like cigar shaped. They are auxiliary crystals seen in ethylene glycol poisoning. Then you can see chocolate brown color, which is suggestive methemoglobinemia. Then you can look at the anion gap in the blood gas analysis. Normal is about 10 to 14. For increased anion gap, the mnemonic is mud piles like methanol, metformin, paracetamol, INH and iron poisoning, ethylene glycol and salicylate poisoning. You can also look at osmolar gap, which is the difference between measured osmolality and the calculated osmolality. If it is more than 10 milliosmol per liter, this indicates poisoning with certain toxins like mannitol, not commonly seen, but alcohols are important. All alcohols, ethanol, methanol, ethylene glycol, and isopropanol. Now, during COVID time, we had a lot of patients with isopropanol poisoning. Now, this patient came to us with injection of nephrine balls. Now, nephrine balls can produce hemolysis, and this can lead to hemoglobin urea. The first urine was dark green color because of hemoglobin urea, which gradually cleared over the period of time. You can also use the urine test for qualitative analysis, for diagnosis. And there are urine tests available for drugs of abuse. But remember that a positive or negative urine analysis does not exclude or does not rule in or does rule out an overdose, because there are several false positive and false negative reports for this. Quantitative analysis in the blood test can also be useful because it can predict subsequent toxicity or can guide specific therapy. So these are useful for iron toxicity, paracetamol toxicity, digoxin toxicity, and methanol toxicity. Now, these are the antidotes which are available to us, particularly for the antidepressant, we have sodium bicarbonate. For cholinesterase inhibitor, we have atropine. For INH is pyridoxine, that is vitamin B6. For methanol is ethanol. So we can give oral ethanol to the patient. So every ED should have ethanol available to it, particularly during holy period. For paracetamol, we have N-acetylcysteine. For opioids, naloxone. For snake bite is antivenom. Now there are two important antidotes which are recently come into picture. One is intravenous lipid emulsion, which is useful in patients with local anesthetic induced systemic toxicity. So there it has been. This is the main indication for using intravenous lipid emulsion, but it also be used in many other toxicities also as last intervention. The second one is the high dose insulin euglycemic therapy, where we give high doses of insulin along with dextro to maintain euglycemia. It is one of the important antidote for severe calcium channel blocker and beta blocker toxicity. It is also used in tricyclic antidepressant and selective serotonin reuptake inhibitor toxicities. Here we give a high dose of insulin, that is 1 unit per kilogram of insulin, plain insulin intravenously, along with dextro to maintain euglycemia, generally 1 gram of dextrose per kilogram intravenously. And then we titrate the insulin dose along with dextrose to maintain euglycemia between the range of 100 to 250 milligram per deciliter. Most of my patients require potassium, but this is going to cause hypoglycemia. Now, this is one of the most important treatments, supportive care. That is support of central nervous system in terms of managing seizures, managing a patient who is in coma, support of cardiovascular functions in terms of managing cardiac arrhythmias, hypotension or hypertension, supporting respiratory functions in terms of managing ventilatory functions, support of renal functions and liver functions, controlling fluid, electrolyte and acid disturbances, and controlling hypothermia and hyperthermia. If we have we support the systems, the patient is likely to come out of the poisoning. Now coming to briefly about medical legal issues. So we should not go by the Munna by MBBS thing that we must get the paper made first and then treat the patient. So inform police only after initial management of the patient. That's very important. Prepare medical legal report. Preserve urine, blood, and vomiters if it is available. Do not be under impression that lavage has to be done in all patients because of medical legal responsibilities. If it is done because it is medically indicated, then only lavage has to be preserved. Properly label the specimens, affix your signature at the neck of the bottle. Now, do not use the glass bottles, which are basically for the IV fluids, or the plastic bottles for the IV fluids. Use proper bottles, which are glass bottle with metallic cap, with no hole in the metallic cap, for preserving the bottle, for preserving the specimens. And they label it, close it, or with the gum that what is called paper gum. Do not use the leucoplast to close it. Just a brief about psychiatric evaluation. Now, every patient who is discharged from the emergency department or discharged from the ward should undergo a psychiatric evaluation, because majority of the patient would have taken the poison with the suicidal intent. So always have a psychiatric evaluation before discharging a patient. So now just this is a case scenario to have overall management of a patient with acute poisoning. So we have a 25-year-old patient who presented with altered sensorium after consuming unknown agent about 90 minutes ago. His oral cavity was full of secretions. clothes soiled with urine and stools. So here we know that the airway is threatened because of the oral cavity is full of secretions. So the first step is the patient must have undergo suction of the oral cavity. So respiratory rate is 28 per minute, saturation 80%, the chest has bilateral capitation rhonchi. So of course, the patient is in altered sensorium. The pulse is 110 per minute, the blood pressure is 70 systolic. Now here we know that patient has got hypoxia, his chest is full of crepitations, he's got hypotension. So patient would require intubation. Now he's in altered sensorium. So with cervical spine immobilization, intubation is required in this patient. In addition, he has got hypotension. He's hypotensive. He would require intravenous fluids, as a bolus of fluid is required in this patient. The pupil was constricted. So this whole thing amounts to a cholinergic poisoning. So this patient will require a dose of atropine in like 1.8 milligram to 3 milligram atropine. Then watch for the cholinergic feature every 5 minutes. If there is no response, double the dose of atropine every 5 minutes. Now remember, his clothes were soiled with urine and stools. Also, he was in altered sensorium. So in every patient with altered sensorium, check his blood sugar. Blood sugar was 95 milligram per liter, which is normal. His clothes was full of stools and urine. So after first few doses of atropine, disrobe the patient, give a bath to the patient, clean the patient. Be careful not to get yourself exposed. So to summarize, resuscitation and supportive treatment are the most important treatments in a patient with acute poisoning. Antidotes may be used wherever they are required. Gut decontamination is only in very selected patients. There is no role of forced diuresis. Benzodiazepines only are the treatment for seizures. Sodium bicarbonate for the QRS prolongation, and magnesium sulfate for QT prolongation. And of course, treat the patient and not the poison. Thank you.
Thank you, sir, for such a very informative session. There are some questions in the chat box. One is, so there is a comment. Excellent talk. Serious autonomic disturbances or reported in cholinergic and other poisoning. During recovery after intervention, do you do scoring for autonomic disturbances or loss? By Dr. K.K. Deepak.
Thank you, Dr. Deepak. Autonomic disturbances are there in many poisoning patients, but in the emergency department, we really don't do any scoring system. During recovery also, the autonomic symptoms generally disappear. And we really don't do any scoring system also in the emergency department or even during the ward also. I know because Dr. Deepak has done many autonomic disturbances, has just studied many autonomic disturbances in patients with poisoning also. But I think you're done in patients with chronic poisonings, not in acute poisonings.
Thank you, sir.
Thank you for the answer.
So there is another question. Apart from the short-term management, what are the most important areas to focus in long-term management?
See, if you see organophosphate poisonings, after recovery from the cholinergic crisis, some of these patients can develop so-called intermediate syndrome between 24 to 96 hours. So they can suddenly go into respiratory failure, proximal neck weakness, proximal limb weakness, and cranial pulses. So they would require basically ventilatory care, which may be sometime for a week or so. Some patients with organophosphate poisoning can also develop organophosphate-induced sensory motor neuropathies 2 to 4 weeks later on. So they can persist, they can improve. It depends if there's no treatment for that also.
Sir, can I ask a question?
Yes, sir.
It's a very informative presentation and very practical tips for management of different types of poisoning which we come across day in, day out. I understand that insulin poisoning, can it be diagnosed? And what are the clinical findings in a patient who have been given overdose of deliberate insulin, high dose of insulin?
Insulin, basically, there are two types of insulin. One is a short-acting insulin, the second one is a long-acting insulin. So if patient has taken short-acting insulin, see, both will cause hypoglycemia. So if it is a short-acting insulin, it will be there, hypoglycemia will be there for a few hours to maybe a day or so. Long-acting insulin can cause hypoglycemia for a longer period of time, but maybe for 36 hours or so. So the presentation is only hypoglycemia only. So there's nothing else beside hypoglycemia.
If somebody has given a deliberate large amount of insulin to a patient, what will happen to that patient?
It's hypoglycemia only. So it will basically patient with hypoglycemia. If you don't diagnose it, the patient will die. So any patient with altered sensorium, the first thing is to check the blood glucose. If blood glucose, see, a patient with insulin overdose will respond to hypertonic dextrose. Patient with oral anti-diabetic agent like sulfonylurea may not respond to oral dextrose. They may require octreotide and sometimes glucagon also. But insulin patient with overdose will respond to hypertonic dextrose.
Dr. Riddhi has mentioned special thanks to Dr. Padma ma'am and Dr. Agrawal sir for such knowledgeable sessions. So, is there any other questions from anyone? If there are no more questions, now I'd like to invite Professor Ajay Kumar Sood sir to deliver the vote of thanks.
Thank you very much. It is indeed my pleasure to express thanks on behalf of National Academy of Medical Sciences to our esteemed speakers for this evening, Professor M.V. Padma Srivastava ma'am and Professor Praveen Agrawal sir. So thank you so much for a very interesting lecture session in which you have given some very practical hints to our PG students, and we look forward for your support in future also. NAMS is also grateful to the chairpersons, Professor Kameshwar Prasad and Professor Meenu Singh for chairing these sessions. So thank you so much, madam, and sir, we look forward for your blessing in future also. As far as the students are concerned, we are really grateful those who have joined. And again, I would like to make an appeal to all the students who have registered with us to come forward and ask your questions, ask your queries. You can send your questions and queries in advance also, so that we can put these questions to our speakers so that these issues can be covered during the lecture session. Another point I want to remind to all the participants, as our president has announced today, that you please participate in this competition of designing the logo for this Navigate CME program. And there is a 2 weeks time. So within 2 weeks, if you send us the logo, and as mentioned, the best logo will be selected and given a prize of 10,000 rupees. So, and again, I want to remind you that next session, which is due in the month of March, on 5th of March, again, we are going to cover 2 very interesting topics. One is on how to manage a patient with head injury, and the second topic is on spinal trauma. So please be with us next time, or remember to be with us on 5th of March. So with these words, I once again, thank you all. Thank you for being with us. Good night.
Thank you, sir. So I conclude the session. I conclude that this current academic session is closed today. Thank you.